Welcome to Grand Rounds May 2025. Today we have two presenters. First is Dr. Lefebvre talking to us about return to sport, and the second is Dr. Manasurangkul, who is talking to us about movement variability. So Dr. Lefebvre graduated from University of Dayton with a Bachelor of Science in Biology and earned a Doctor of Physical Therapy from New York University. She's currently a resident in the St. Luke's University Health Network Orthopedic Physical Therapy Residency. She is a certified strength and conditioning specialist and also a credentialed clinical instructor. Dr. Lefebvre is actively involved in research focusing on criteria-based return to sport testing for arthroscopic Bankart repair. Dr. Manasurangkul graduated from University of Pittsburgh with a Bachelor of Science. He then earned a Master of Athletic Training degree and followed by a Doctor of Physical Therapy degree, both from Moravian University. He's currently Chief Resident in the St. Luke's University Health Network Orthopedic Physical Therapy Residency. He previously worked as a strength and conditioning coach where he developed a love for helping his athletes to refine their movement strategies, develop strength, and reduce their risk of injury. This has influenced his treatment philosophy by utilizing strength training, patient education, and hands-on skills to improve patient autonomy and outcomes. If you didn't hear me earlier, please make sure that you sign in with the QR code or the sign-in code. And at the end of the presentation, please make sure you complete not only the quiz, but also the course evaluation so that you get the appropriate CE or CME credit. This is our CME credit information, our description of need, and it is for all providers. And this is our designation statement. And the planners and presenters have nothing to disclose. Overall, of the two parts, by the end of this course, we want you to be able to explain the importance of sport-specific return to sport criteria, identify and prevent upper extremity injuries in the healthy athlete, define movement variability, and recognize the role of movement variability has and its role in lower extremity injury prevention. So, without further ado, I will turn this over to Dr. Lefebvre.
Hi. Hello again, my name's Abigail, and I'm an outpatient orthopedic physical therapist. I will be presenting today on return to sport criteria for the upper extremity athlete. Return to sport is defined as a measure for assessment of clinical outcomes in orthopedic sports medicine surgery. There is no standard definition regarding when an athlete has officially returned to sport, as some clinicians consider return to sport to consist of returning to practice, while others consider it to be returning to full competitive play during a match or a game. Because of this lack of standardization, it is important to specify what return to sport means to you and your patients when performing testing and setting goals. Despite an uncertain definition of what return to sport is, we know that it is a way to prevent re-injury, including instability, assessing and evaluating functional recovery, and providing an objective measure to guide the athletes back into his or her specific sport. When considering what to look at when looking at return to sport training, objective and subjective measures are a great place to start. Some measures include tissue healing time, strength measurements using a handheld dynamometer, or range of motion, patient-reported outcome measures, including DASH or NPRS, and physical performance tests. Physical performance tests typically come to mind for most clinicians when return to sport is considered. However, it is only a piece to the puzzle. When considering what to focus on during return to sport testing, it is important for us to consider recurrence rates. Research shows higher recurrence rates in youth athletes following non-operative management compared to operative management. Approximately 5 to 10% and up to approximately 17% of athletes following an arthroscopic anterior stabilization surgery find themselves to suffer from further instability episodes. An important note to point out is that recurrence rates change depending on the type of sport, as collision sports can have a recurrence rate as high as 92%. A popular conflict between clinicians is which to place greater weight on, either return to sport testing or time-based clearance, which focuses on tissue healing times. Reddy et al.'s 2023 study compared recurrent instability and return to play in young athletes who underwent clearance to full activity based on validated return to sport tests to those who underwent time-based clearance following primary posterior labral repairs. They concluded that return to sport testing in young athletes following posterior labral repairs did not reduce recurrence or improve return to play compared to time-based clearance, as 2/3 of the athletes who underwent testing failed at least one section, which indicated some functional deficit. Thus, return to sport testing may help guide postoperative rehabilitation following posterior stabilization. Junior et al.'s 2021 study aimed to analyze the impact of criteria-based return to sport testing protocols on recurrent instability following arthroscopic Bankart repairs. They hypothesized that patients who underwent an objective criteria-based return to sport testing protocol to guide their clearance to return to sports would have less recurrent instability than those who did not undergo testing. In conclusion, the athletes who underwent an objective criteria-based return to sport testing protocol to guide their clearance to return to sport had a lower rate of recurrence instability following arthroscopic Bankart repair than those cleared to return based on time from surgery. Athletes who did not undergo the testing after an arthroscopic shoulder stabilization surgery had a 4.85 times greater increased likelihood of recurrence instability developed after returning to their sport. Ryman et al.'s 2023 study looked at the reliability of upper extremity functional performance tests for overhead sporting athletes. They looked at the 4 tests, specifically including the prone medicine ball drop test at 90 degrees of shoulder abduction and the prone medicine ball drop test at 90 degrees shoulder abduction and 90 degrees elbow flexion. The half kneeling medicine ball rebound test and the seated single arm shot put test. They concluded that there was significant reliability with the half kneeling medicine ball rebound test and seated single arm shot put test. Thus, they recommend these 2 tests to be used to advance a patient through a rehab program, and also will be utilized as criteria for progression to return to sport. Olds et al.'s 2019 study looked to establish the reliability and responsiveness of a clinical test battery developed to determine readiness to return to sport after an upper extremity injury. It was concluded that 6 of the 8 tests in the test battery demonstrated good psychometric properties to evaluate both open and closed chain upper extremity activities, indicating the readiness for clinical use. It was noted that the ball abduction external rotation, side hold rotations, and push-up claps needed a familiarization session in order to achieve an accurate testing result. On the slide here, it indicates the 6 out of 8 tests that were considered reliable. These were the ball abduction external rotation, overhead snatch, modified closed kinetic chain upper extremity stability tests, the push-up claps, the line hops, and side hold rotations. The two unreliable tests were the drop catches and the ball taps. These were shown to have a learning effect across the testing. Thus, scores can improve without actual progress being made. Here are the open chain tests, including the ball abduction external rotation, which is the first one on the upper left of the picture, and the overhead snatch, which is the bottom right of the photo. I'm going to go a little bit more in depth into the closed chain tests. First, we have the modified closed kinetic chain upper extremity stability test. The starting position is in the push-up position with the hands placed on two lines about 36 inches apart with feet shoulder width apart. The athlete will alternate touching each hand to the opposite line as many times as possible in 15 seconds. The hands must then return to the starting position before the next touch. The test is performed 3 times with a 45-second break between each bout, and the average of the 3 is taken while the score is determined based on height and body weight of the athlete. The push-up claps start in a push-up position with hands about shoulder width apart. The athlete bends the elbows to lower their chest to the ground, followed by an explosive push-off of the ground to lift the hands off of the floor. While in the air, they will clap their hands together before returning to the original position to catch themselves. The movement is repeated for a specific amount of repetitions, indicated pending the protocol used. The line hops focus on the athlete will use one arm to hop back and forth over a 2.5 centimeter line in a kneeling position with the hips extended. And the side hold rotations have the patient starting in a side plank with the arm up to the ceiling. You will wrap underneath, looking at the mat, and then go back to the original starting position. Wilson et al.'s 2020 study evaluated the ability of post-operative patients who underwent arthroscopic shoulder stabilization surgery to meet expected goals by using standardized objective evaluations of strength and physical function. The closed kinetic chain upper extremity stability test and the unilateral seated shot put test were used to assess shoulder function. A significant number of athletes did not meet the expected goals for their operative shoulder in achieving appropriate function and strength compared to the contralateral shoulder. Functional goals were more often met than strength, and internal rotation strength goals were more frequently met than external rotation strength. Strength and functional testing could provide more reliable criteria than arbitrary passage of time for return to play after shoulder stabilization surgery. Next, we're going to look at a couple preventative programs that focus on preventing shoulder injuries. The throwing injury prevention programs are important in athletes who partake in high volume and intensity throwing activities. An important deficit noted in these athletes is GERD, also known as glenohumeral internal rotation deficits, scapular dyskinesis, posterior shoulder weakness, and hip internal rotation loss, which all place the athlete at risk for injury. Younger athletes are the greatest at risk as they are more likely to have excessive pitch counts, and when combined with skeletal immaturity, results in fatigue, making them more susceptible to compensations and injuries. This program focuses on 3 things. First, stretching, specifically to reduce GERD, but also hip internal rotation and thoracic mobility to maintain proper kinetic chain function. In addition, dynamic mobility and balance training are used to improve coordination to reduce re-injury risk. The throwing prevention program was found to reduce injury significantly at 52%. Next, we will look at the FIFA 11 Plus Shoulder Injury Prevention Program, which targets goalkeepers and is effective at reducing upper extremity injuries by increasing shoulder strength and stability. The key components of the program include a warm-up, focusing on general aerobic exercises to increase blood flow and prepare the muscles for activity, strengthening exercises, which look at external rotation with resistance bands, which target the rotator cuff muscles to improve shoulder stability, and scapular stabilization exercises, which focus on strengthening the muscles around the scapula to ensure proper movement and support during overhead activities. Dynamic stabilization exercises, which include push-up variations, including push-ups with shoulder taps to enhance dynamic stability and coordination, plank variations, including side planks and front planks with arm lifts to engage the core and shoulder stabilizers. Next, we look at flexibility and mobility, which includes the sleeper stretch to address GERD, and thoracic mobility drills to improve overall shoulder and upper back flexibility. Lastly, it includes neuromuscular control, which is proprioceptive drills, such as ball tosses while maintaining a stable shoulder position to enhance proprioception and control. Despite the FIFA 11 Plus shoulder program being geared towards goalkeepers, we can implement it for other overhead athletes. Due to minimal research focusing on this program with other sports, it is important for clinicians to educate the athletes on how to use the program pending the athlete's sport. We can instruct the athlete to incorporate the FIFA 11 shoulder exercises into their warm-up routine before training sessions and games. Combine it with other sport-specific programs, monitor workload and ensure adequate rest, and make sure that we keep track of regular assessments and modifications as needed. The FIFA 11 shoulder program has been shown to significantly reduce upper extremity injuries by 68% in soccer goalkeepers, demonstrating its effectiveness in enhancing shoulder stability and reducing injury risks. Integrating this program with other sport-specific and general injury prevention strategies can provide a comprehensive approach to maintaining shoulder health in overhead athletes. Finally, I would like to summarize this presentation. So first off, we discussed return to sport testing, which it depends on the sport, but as clinicians, we are to use reliable and valid tests in order to allow a patient to return to sport. Also, prevention programs. It's our job to educate on prevention programs to prevent recurrence. For questions, we will be taking them at the end of the full presentation. And then here are my references if needed. Thank you.
Thank you very much. And now we will have Dr. Manasurangkul. I will get it someday.
Thank you, Dr. Karaha. So, good afternoon, everyone. My name is Watanai Manasurangkul, and the title of my grand rounds presentation is Movement Variability, Exploring Valgus and Plyometric Progressions. The objectives for today's lecture are to define and understand the concept of movement variability and its role during functional activities, to apply current literature to improve on our understanding of movement variability and how it affects rehabilitation and injury prevention, and lastly, to understand basic plyometric terminology and progressions as well as its role within physical therapy. Starting off, we have our biomechanical definitions. So what is movement variability? Movement variability is normal movement variations that occur across multiple repetitions of a task. The best example of this is when you have a patient squat and you see minor deviations from one rep to the next. You may see changes in valgus angles, ankle pronation, lower extremity recruitment, movement strategies, and torso angles. Keep in mind that these changes are not inherently bad, but they require control, refinement, and education for our patients to understand what a safe and stable functional position is. Dynamic knee valgus, on the other hand, is considered to be an incorrect movement pattern that is recognized as a risk factor for lower extremity injuries. It is comprised of a handful of motions and occur typically in combination. These motions are adduction and internal rotation of the femur, abduction of the knee, anterior tibial translation, external tibial rotation, and lastly, ankle eversion. These factors usually contribute to medial displacement that goes beyond the foot-thigh line, which we will see a visualization of in the next slide. The image on the right hand demonstrates a knee that is in line with the hip and foot, as you can see by the straight line passing through all three joints. This is considered to be a more stable lower extremity position with better neuromuscular control. The image on the left demonstrates medial tracking of the knee that travels beyond the hip and foot line. This is typically associated with poor movement strategies, motor control issues, or strength deficits. But what happens when you fall in between the two examples? What if a patient's anatomy pushes their knee beyond 180 degrees and into varus? Dynamic knee valgus is considered a predisposing factor for both acute and chronic lower extremity injuries, such as ACL ruptures and patellofemoral pain syndrome. It has also been found to be the primary mechanism for ACL injuries as seen in video analysis and cadaveric studies. Because valgus is considered to be a predisposing factor for lower extremity injuries, we have traditionally trained people to completely avoid knee valgus, which we will talk about in the next slide. But is it as bad as we really think it is? An interesting tidbit that I found while researching this topic is that the IT band, TFL, and glute max play a significant role in lateral stability of the knee, and that increased tension on the TFL can impact tibial abduction and increase knee valgus. So if you're struggling to find a deficit or neuromuscular control is not improving, the TFL and glute max can be great places to further investigate, especially since the TFL tends to get overlooked while the glute medius tends to be highly prioritized. For this slide, I want to discuss some previously held beliefs and practices that are still commonplace today. The first one being that knee valgus is traditionally viewed as the angle of the femur positioned on the tibia. However, most functional movements occur in closed kinetic chain, so it's important to consider how the pelvis moves on a fixed femur. This also allows us to assess pelvic motion and stability and its function in the kinetic chain, as the hip musculature is also responsible for attenuating ground reaction forces that impact joint angles. Another common practice is to assess knee valgus with a vertical drop jump test. This is essentially where a patient steps off of a box approximately 6 to 12 inches, and we assess their ability to absorb forces. Now, this test is a fine place to start. However, we all know that athletes and people in general can be excellent compensators. It's our job to expose these compensatory patterns and asymmetries. We should also be looking at our patients' ability to not only absorb forces, but also their force production and ability to transfer forces as well. From an evaluative standpoint, single limb stance is a fantastic way to start for both athletes and general population. From here, we can observe functional weaknesses that are often conveyed through asymmetrical hip rotation, loading strategies, hip drop, stability, foot position, and hip and knee flexion angles. Now, this last point is one I certainly say that I fell prey to a few years ago, and that is the belief that there is a correct way to jump, cut, and move. An interesting study I came across was one that categorized NBA players in their jumping and landing strategies. This study found that there were 3 common strategies that were utilized. Keep in mind that these are the elite, and if there was an ideal way to move and improve their performance, they would quickly adopt it. If there are deviations among the top percentile, why should we pigeonhole ourselves and our patients into one movement strategy? Instead, we should allow our patients to explore movement patterns and develop their own strategies while we refine their movement. There is no gold standard for movement as it varies depending on sport or activity-specific needs as well as individual anthropometry. We want our patients to use strategies that work best for them. There's no need to fit a square peg into a round hole. Before we move into the next slide, here's some food for thought. In gait, it's normal for us to internally rotate, adduct, and pronate to propel ourselves forward and to generate force. This sounds suspiciously like valgus forces. So why are these forces so frowned upon during other functional patterns when we commonly see this pattern appear when we need to generate and absorb forces? It happens at one joint or another. We can see this through increased ankle pronation, knee valgus, and under heavier loading for torso lean, resulting in greater hip IR and valgus moments. It's just something to consider when we rehabilitate our patients and critically think through movement patterns. Regarding prevention screening and evaluation, it is important to assess the entire kinetic chain. Assessing subsystems and slings allow for us to determine weak points in their kinetic chain and also to address strength deficits we may have found in isolation in a more functional manner. This is why it's important to view the foot, ankle, hip, and core during various patterns and see how these individual parts function together. After all, functional movements do not occur in isolation and require coordinating several joints and muscle groups in unison to create stability and power. Utilizing subsystems also helps us to evaluate all contributory factors and planes that impact the functional pattern, which gives us the ability to assess for more relevant deficits. Next, I have listed here are some common compensatory findings that people tend to demonstrate during single limb or plyometric testing. Increased lateral trunk flexion over the stance leg, especially when cutting or with lateral movements, along with greater plant leg distance, is compensation for poor control over their center of mass. Decreased knee flexion can be poor ability to attenuate ground reaction forces, which could indicate poor movement strategies and anticipation of forces. Greater hip and knee angles may be due to poor hip neuromuscular control or strength, leading to increased valgus forces. This slide lists some considerations we should have in mind when addressing lower extremity function. As stated in the previous slide, we should consider the entire kinetic chain, as well as total tension throughout the system to ensure patients understand where they're strong and where they're stable. Because we're viewing the entire kinetic chain rather than just isolated body parts, we should be able to better assess and address deficits that occur in various motions and planes that we want to improve upon, as functional activities tend to occur in 3 dimensions or a combination of planes rather than in one plane at a time. Building off of that, dynamic knee valgus is a multi-planar movement that is used to manage ground reaction forces. It's important to understand that the greater the ground reaction force, the greater the instance of potential valgus. We want to address the various forces that occur in all planes to better control contributing factors for these forces. Lastly, functional patterns often occur beyond what PTs consider to be safe or normal. We see this all the time in sports where higher intensities are required. Basketball players demonstrate valgus when jumping and landing. Olympic weightlifters showcase similar patterns during their lifts. Football players demonstrate significant torso lean and valgus angles when cutting and pivoting. Instead of thinking whether a movement is safe, consider whether a movement is stable and strong for our patients instead. By doing this, we can start to encourage movement pattern discovery and adopting movement strategies to improve stability and efficiency. A recent study explored the concept of controlled exposure to valgus. In this study, they had 3 groups, but to keep it simple, we can condense it into 2. The first group is linear pedagogy, which is where a gold standard of movement was given to this group and everyone was forced to adopt this ideal movement pattern. This falls in line with previous PT practices of avoiding and eliminating valgus movements, as it is considered noise and an increased risk factor for lower extremity injuries. The other 2 categories can be grouped together as they both include exposure to a wide variety of movement variability and encourage self-discovery of movement strategies and adaptations that are specific to the given task and environmental factors. The outcomes of this study demonstrate that increased movement variability improved risk factors for potential ACL tears, regardless of the teaching methodology. Another recent study that I wanted to include was one that observed isolated strengthening of the glute medius, popliteus, and posterior tibialis in college soccer players. While this study found significant changes in strength, the results were below the minimally detectable change regarding dynamic valgus angles. This means that further studies need to be performed, but strengthening in isolation may not have as much carryover for functional patterns unless those patterns are practiced. Based on those findings, here are some treatment options that we can consider to improve outcomes and prevent the recurrence of injury. The first option is to have a controlled exposure to valgus. This is where we allow our patients to play with low levels of intensity and explore movement patterns and see what feels best for them. In doing this, we get to refine these patterns and encourage autonomy for our patients as they get to determine what movement strategies best fit their individual needs. Early exposure to valgus does a few things. It allows patients to determine how much movement variability is acceptable for them to still feel safe, strong, and stable. This ensures that patients are familiar with valgus, or less ideal positions, in a low stress and low intensity environment. If their first exposure to these positions occur as intensity ramps up, or even worse, during competition, where intensity and fatigue are at their highest, this would not be the ideal scenario. To introduce and familiarize a less efficient movement pattern that increases potential risk for injury. And as we saw in the previous slide, exposure to valgus can lead to decreased ACL risk factors as well by discovering and understanding different movement strategies. As we talked about previously, improving functional patterns via subsystems is a fantastic way to identify and address strength and neuromuscular control deficits in a functional manner. This also serves as a wonderful opportunity to educate patients on how to create co-contractions and explore various joint angles where they can generate the most stability, force, and power. As PTs, strengthening is often at the forefront of our minds, which is great. We need strength for both force production and force absorption. However, a highly overlooked aspect of this is the patient's endurance to maintain these levels of force production and neuromuscular control. Previous research has shown that as fatigue accumulates, the hamstrings and calves' neuromuscular capacity to limit anterior tibial translation inversely decreases. Remember that without endurance, all the strengthening and neuromuscular control training that we do will not be nearly as effective during higher levels of intensity. Lastly, we have plyometric progressions and varying levels of complexity. Adding complexity to these movement patterns challenges our patients neurocognitively as they problem solve to discover improved movement strategies. Complexity can be scaled by combining the listed movements of leaping, bounding, and hopping, adding in varied intensities, changes of directions, as well as dual tasking. In this slide, we define common plyometric terms. Leaping or jumping is a plyometric movement that involves a bilateral base of support. So two limbs coming into contact with and leaving the ground simultaneously. This can occur in a squared stance or a staggered stance as a progression towards skipping. Skipping is a plyometric movement that involves an alternating single leg base of support. You may have also heard of bounding, which is a form of skipping that's more akin to exaggerated running. Hopping is a plyometric movement that involves continuous jumping on the same lower extremity. Yield is the amount of tissue deformation that occurs during the amortization phase, where we transition from force absorption to force transfer and force generation. The amortization phase is exactly as I stated before, but more specifically, it's the period between the eccentric and concentric phases of a plyometric movement. Think of it as a phase from when you first land and absorb forces to when you're about to begin your takeoff and generate forces. Here are some overarching goals and considerations we should have when programming plyometrics for our patients. The first being that we need to prioritize quality and not quantity. There are several other ways to improve aerobic capacity for our athletes. Instead, we should focus on the athlete's rhythm and coordination, as well as their timing and sequence. This allows us to better identify their movement strategies and deficits. For example, we can see how a patient generates force through their lower extremities only versus when using their upper body to help accelerate and decelerate. We can alter their center of mass by having them hug a medicine ball. We can also see how they're able to accept and transfer forces. Now, we often hear about staying stiff during plyometric movements, but there's a difference between tendinous stiffness, which requires appropriate sequencing of our muscles and joints, versus just being plain rigid when landing. The next bullet helps to determine the level of intensity and volume for our patients. High movement variability occurs with low displacement and low intensity with higher volumes, where we encourage exploration and freedom to play around with movement patterns and strategies as they warm up and get accustomed to plyometrics. The more intense and greater the displacement, the lower the movement variability should be, as the increase in forces also increases the potential risk for injury. The last main bullet determines what our plyometrics should consist of and what level of readiness, their specific needs, and their deficits. If they are newer, it may be more beneficial to begin with higher yielding plyometrics, so we can create tissue adaptations with decreased forces and improve on their ability to absorb these forces. Perhaps they're ready to progress and their sport requires decreased contact time. This is where we can utilize pogo jumps or hops to minimize tissue and joint deformation and improve reactivity off of the ground. This also allows us to improve efficiency regarding force absorption and force generation. Lastly, we can aim to improve force transfer in multiple directions. First, we can string together consecutive broad jumps and progress to transitioning from lateral to sagittal planes, or add in rotational components while still maintaining momentum and force production. There are a few variables that we can change when programming plyometrics. The first being the amount of yield. Starting off, we have deep yield, which is where deceleration occurs in the lengthened portion of the movement. Consider deep squat jumps or lunge jumps where the knee nearly contacts the ground. Fixed yield is where we purposefully stop in the mid-range of a motion. This segues as a progression to minimal yield, which is where we have the least amount of tissue deformation and least amount of ground contact time, which is seen by pogo jumps. It's also prudent to consider intensities when we have determined our patient's preparedness levels. Low intensity is characterized by low levels of displacement, low force production, high movement variability, and the perfect intensity to explore movement patterns and learn new movement strategies. This also serves as a great way to warm up and progress to higher levels of intensity. Now, submaximal is my personal favorite and where I believe most plyometric training for prepared athletes should take place, as this is the intensity that most plyometric movements occur during competition. Here, we're able to continue refining strategies with increased intensity and force production. We can ingrain good patterns here because we can also improve on their plyometric capacity. Maximal effort should be more rare, as most athletes are not quite at the preparedness level to tolerate consistent and repeated bouts of maximal effort plies. This is most commonly used during testing because we can determine max force generation and absorption, reactivity, and their ability to transfer forces at high levels of intensity. The following are the more often considered variables, such as progressing double limb to single limb. I would urge to bridge the two by going from a squared stance to a staggered stance. Staggered stance leaping and shuffling can be done continuously or in an alternating fashion to better simulate skipping. From here, we can progress into skipping and bounding, which has higher amounts of force and displacement involved. Lastly, we can progress to hopping and other advanced high force plyometrics. To further add complexity, this is where we can combine these progressions and move from 3 strides into a hop or a bilateral takeoff into a lateral hop to overload the limb and add a change in direction. Adding in cognitive tasks, such as having a target to land on or using auditory or visual cues, or adding in perturbations are great progressions for return to sport athletes. Here are some basic progressions I mentioned throughout the presentation, just listed out visually. I want to especially highlight a few here. Jumping with hands on hips versus with arm drive lets us see coordination of the upper and lower body, as well as how the lower body functions when the upper extremities are taken out of the equation. Upper extremities can certainly be used to compensate for poor movement patterns. Changing center of mass really challenges movement strategies and how to adjust. Think of how pads affect a football player. Split stances are, like I mentioned before, an excellent progression towards single limb plyometrics. Skipping and bounding are great, but what is often underutilized is combining skips with hops so the pattern becomes more forgiving, but also more cognitively demanding as well. Lastly, we all know what hopping is, but a great way to progress this is also to include cycling, which is where the hopping leg turns over during the hop to simulate a sprinting stride. We'll see a video demonstration of this in the next few slides. Here on the left-hand side, we can see a demonstration of hands on hips, followed by varying levels of yield, intensity, and displacement. These all range from minimal to high and from low to submaximal intensities. Next, we'll also see continuous leaping with sagittal displacement going both forwards and backwards. Now, on the right-hand side, we can see a similar progression, but now with upper extremity sequencing. Note the sequencing of the upper arms during landing and takeoff and how they stay consistent regardless of the intensity, displacement, or yield. Lastly, we have continuous low yield leaping with alternating directions, going laterally and now sagittally. The first video demonstrates staggered leaping with varying yields, ranging from minimal to fixed to deep yielding. Take note of the increase in ground reaction times, the greater the yield. Following this, we'll have a skipping progression, ranging from a bilateral base of support, and next to low intensity skipping, and now submaximal skipping. And lastly, the most intense of them, bounding. As you can see, there is a change in technique from skipping to bounding, but they're both still performed with an alternating unilateral base of support. The second video demonstrates a hopping progression, beginning with a combination of a skip into a hop to avoid consecutive jumps. We then progress to submax. Oh, that is not going through. And then we'll see a progression from submaximal hopping. And lastly, we have maximal effort hopping with a cycle. And it's not letting me play. Oh, that's a different plyometric progression. Having some technical difficulties on the last one, but want to showcase this last video right here, which shows an example of how to progress hopping, where we transition from a sub-maximal sprint to a maximal hop with a cycle to improve force transference and the preservation of momentum. To wrap things up, here are the following main takeaways I hope everyone got from this lecture. Allow for exploration and discovery of movement patterns and strategies. This improves outcomes, builds confidence, and facilitates the development of autonomy in our patients. It's important to refine movement patterns, but to also understand that there's no gold standard for how each person needs to move. Remember, to assess for movement deficits in isolation as well as functionally. It's totally appropriate to improve these deficits in isolation, but that we must reintegrate them into functional patterns for improved carryover. Remember to assess movement strategies as you improve on these deficits to see if other changes need to be made. Utilize appropriate plyometric progressions to facilitate playtime, confidence, neurocognitive skills, tissue adaptation, power production, force absorption, and transference. Lastly, consider other environmental factors in a patient's sport. Utilize visual and auditory cues. Incorporate perturbations. Use uneven and pliable surfaces to better replicate competition. Add dual tasking to increase stimulus and demands that go beyond competition levels of intensity. Here is a list of my references, and that concludes my Grand Rounds presentation. Thank you everyone for listening.
So, what questions do you guys have? Either feel free to type it into the chat, which I'm monitoring, or unmute yourself and ask. Actually, while we're waiting, I have a couple of questions, or a question for Dr. Lefebvre. Actually, yeah, if you could. So, some researchers, as you know, have found that some of the return to play is a little strict or seems strict to the point that they argue that healthy people can't achieve it. What has your research found so far, and what is your response to that? Do you think it is too difficult, or?
I think it's hard to say 100% because a lot of return to sport protocols include a variety of different tests where the research kind of looks at different tests specifically, so not all of the tests together. So I think it's really hard to say, yeah, an athlete is unable to achieve the completion of a return to sport protocol unless that specific protocol is looked at.
What is do you feel that it's an indication of future injury though, or do you think it's just too strict and some return to play protocols should be eased?
I would say it is more of there's functional deficits apparent that every protocol looks at something different. And sometimes you'll miss a couple things, right? And those little things that are missed could be the biggest piece to the puzzle and cause that recurrent injury. So I think the biggest thing with just a general protocol is just making sure that you're hitting every single spot that you possibly can in order to look for any type of deficit. Because even some of the protocols looked at internal rotation of the hip, even just that in pitchers not having that full internal rotation could result in injuries up the chain.
Okay. Cool. Thank you. And actually, my next question is for Dr. Manasurangkul.
Nice job.
Off of that, a lot of return to sport looks at movement analysis and grading based upon failure to hit the quote unquote gold standards, such as the squat. But as you pointed out, there's really no gold standard for a squat if you look at the literature as a whole. So what is your thought on that? And then what is your thought on carrying that into a neurologic population, somebody who's had a stroke? Is exploring of the of movement variability something that could help them as well? I guess it's two questions.
So to tackle the first one, I think that the gold standard that we've kind of given a lot of athletes and patients are just the majority of people fall in this category. This is how most bodies kind of function. And that's where I think that that's totally okay if they fall under that category. If their limbs allow for you to squat the way that we see it in a textbook, that's totally appropriate. But if you have someone who's 6'4", trying to barbell squat and say, hey, why can't you hit depth? Why are you having so much forward torso lean? maybe we need to take a different look. Maybe we need to assess and see why they're unable to perform those squats. In my personal experience, usually if you wedge these athletes, they're able to perform a squat beautifully. But when you take that away due to the biomechanics of their femur/tibia lengths, that's when we're usually going to run into some problems. And I think that my talk is mostly just to say that it's okay for people to move differently. It's okay for us to not have a picture perfect squat. We see it all the time in our normal day-to-day life and in competition. Things do not have to be picture perfect. We can look to refine that and decrease some movement variability, but we should give them the room and autonomy to explore that and see what works for them. If we give them that autonomy, they're going to do much, much better because now they're learning strategies instead of just being forced into a cookie cutter pattern. And this is where I think that physical therapists can do a fantastic job, but we need to pay more attention and be much more open-minded and communicative with our patients to see what feels best for them. And I think that also goes into the art form of physical therapy. It's not necessarily just cut and dry, this is how you have to do things, but there's a certain way that we can connect and educate our patients so that they can get the most out of their movement patterns. In regards to the second question for the neurologic population, I think that's really important because you're focusing so much on their function that as long as they're moving, I'm pretty okay with that. If that's how they best do things, that's okay. It doesn't need to be picture perfect for them to go about their normal day-to-day life. If we're looking for them to just accomplish their baseline goals, do they need to move the same way that an elite athlete would? I don't think so. And that applies both orthopedics and for the neurologic population as well too. And I think for the neuro population, it would be so interesting to see how they go about troubleshooting these movement strategies and trying to improve on their coordination skills, because a lot of these movements are challenging to figure out, and to see them kind of go through and troubleshoot and see, oh, I need to move in this way or bend in this way for me to generate more force, to feel more stable. And that is actually a question I ask very, very commonly in my patients and athletes is, do you feel more stable doing it this way or that way? And that is usually a pretty fine metric in regards to if they're comfortable doing it that way. We can continue to refine it and ask that question again if they feel even better. And if not, we go back. We can do it their way as well too. That's totally fine.
Thank you.
I have a follow-up to that question. That's Dr. Harris' first part of this question.
Sure.
So in your practice, a lot of your presentation focused on, there was little mention of pain. So if somebody has a movement variability that we're not accustomed to seeing and it's painful, are you training them in a variation of their own movement pattern to get them out of pain? Or are you going to strengthen them in their movement pattern?
That is a fantastic question. So, in my own practice, I shift. So I think of movement variability as, let's take someone who we see and their squat pattern, their movement pattern does not look the prettiest to us. It's not textbook. So that's on one side of the spectrum. And on the extreme side, we have it where it looks either picture perfect or even exaggerated into maybe varus if we're talking about a squat. I usually like to go from their extreme and the other extreme and kind of meet in the middle. See what they're comfortable doing. Maybe we make some of those changes. Maybe their pattern has led them to being in a more painful position. So if we continue to improve on their control of that pattern, it doesn't need to be, like I said, no valgus at all. It could have some. I don't think that there's anything wrong with that. But allowing them to explore and see what gradually starts to feel better. If the way that they've been squatting creates pain, try this, add this. Does that change how you feel? Do you feel more powerful? Do you feel more stable? Does that affect your symptoms at all? And then we can go from there. So I think that our job should not be to tell patients how to move, but to help educate them and refine their movement pattern instead. And that's where we can do a much better job of not putting people into the same cookie cutter movement strategy and pattern, and help them discover what works best for them and what they need to do. The pattern for someone who is looking to garden is going to be different from someone who needs to do like construction work, compared to someone who needs to play football as a lineman, where they're encouraged to have valgus. And then that differs from a jumping athlete, for example. So we're looking to refine strategies that fit the patient's needs and their sport, their activity, and their anthropometry.
What other questions do you guys have?
I have a question if nobody else does. The plyometric progression or the learning, I forget exactly how you had it phrased, but learning to do plyometric exercise. Did you develop that, or is that like something that was in the literature?
So I was not able to find a lot of significant studies in regards to the appropriate progression for plyometrics. This came from my own practice as a previous strength coach. And to me, this is also just common variables that we would change for basic exercise principles, just applied in a different manner. So we're taking things and making them more stable, less complex, less displacement, and gradually adding one variable or changing one variable, making it more complex and building off of that. I think that for plyometric progressions, at least from what I've seen typically, is that there isn't much of a progression. There isn't much of a determining of the patient readiness. And we tend to jump from one category of plyometrics to the next without actually putting as much thought into what that exercise is doing and what goals it's looking to accomplish for us. So that's something that I've kind of put together. There are also a few other, I'm sure, schools of thought that share similar things. But these are the findings that I have had, and also just like seeing what other strength coaches or other physical therapists continue to do as well too. And in my case, I've tried to rationalize it and see, oh, does this make sense? Are they able to progress through this safely? And does that actually work in that manner? Can they skip steps? Sure. But we want to make sure that we're still progressing them safely and allowing them to accomplish the goals that they want to accomplish, but also the goals that we have set out for them as well too.
This may be a question for both of you, but do you feel like the safety of progression through any of the things of return to sport is more related to, I mean, it probably could be both things, like tissue adaptations or like motor control, and how do you kind of evaluate the difference between the two?
You want to go first?
You can go first since you're there. I'll go second.
Okay. So I think that the best way to assess this is to look at how a patient is first moving. Are they able to perform the most basic of these, at least in regards to my talk, plyometrics and lower extremity motions? Are they able to move dynamically at the very baseline? And then from then, are we able to progress them in regards to their capacity to handle a lower or a higher yielding plyometric? That's where we can see, can they absorb less force, but in a longer position? And that's where they have more time to be able to adapt and to develop that movement pattern and strategy. A lot of times, like I talked about before, the musculotendinous adaptation and sequencing. So that's where you can see someone who knows how to land quickly and generate that force versus just laying really rigid and stiff. You can see that difference. So for us to gradually improve that quality of motion and how they're able to handle those forces is much more telling to me of their tissue adaptation and preparedness levels for progressing them to the next level of plyometrics and so on and so forth. I think both tie in hand in regards to motor control and movement quality, as well as the tissue adaptations, because they're just going to be more accustomed to that learning curve and then being able to build off of that.
Yeah, so kind of going off what Kane said is that over time, like we want to look at that neuromuscular re-education first, and you don't really progress until that's achieved, right? Or else you're going to be resulting in other compensations. By doing that, also though, it's important for us to look at exactly what the sport is, right? So bringing back to those tissue healing times, considering tissue healing times with return to sport, it's important for us to consider that, right? But it can't be all return to sport protocol testing and all tissue times. And I think the tissue time healing comes first, right? So we do that neuromuscular reeducation and that tissue healing time. And then that's when we kind of get into what Kane was doing, a little bit more progression and see what they can tolerate. And then you look at their sport specific stuff and how much are they going to have to explode, right? And you're going to progress from there. So I think it all comes together, but in terms of what sport they play, it determines the order in which things need to be achieved.
Thank you.
All right. Well, we are out of time, and thank you very much. I apologize for the technical issues that we have today. If you have further questions, please reach out to either presenter or to myself. And make sure you take your quiz and your course evaluation to provide feedback. And we will see you next month.